Hello and welcome. I'm Professor Ian Hickey, Co-Director of Health and Policy at the Brain and Mind Centre. And this afternoon we'll be discussing maximising the use of digiHealth solutions in youth mental health care. This is number 6 in our seminar series about how to implement the Brain and Mind Centre's enhanced youth care model. And on this occasion, we'll be taking that model through each of its steps and see how the use of new technologies may well assist with that process. Just to start with, as always, I'd like to acknowledge the traditional owners of the country on which the University of Sydney's Camperdown campus is based, the Gadigal people of the Eora Nation, and recognise their contribution to learning and development in this country over many centuries. I'd also like to recognise those with lived experience of mental health problems who've contributed so much to our knowledge base and their expertise in taking these issues forward. So, this is number 6 in the seminar series. We will briefly review what the other 5 have been about and then how the use of digiHealth solutions fits into improved youth mental health care. So, in the first seminar, we talked about what the Brain and Mind Centre's youth model is, its multidimensional assessment and outcomes framework, and how it seeks to treat an episode of illness, but also to prevent progression to more complex and severe forms of illness. And that is no simple diagnostic process, it's no simple categorization process. There's complexity, but we have been investigating that complexity now over many years and looking at the ways in which it can actually be taken forward. In the second seminar, we looked at really the transdiagnostic framework, the clusters of symptoms and syndromes, how they come together, how they can be used in association with clinical staging, a very important concept that we've introduced into clinical practice with our friends and colleagues from Origin Youth Health and Professor Pat McGorry in Melbourne, but also how we use unique conceptualizations of pathophysiological mechanisms and illness trajectories, which are different to stage, to classify what illness journey a person may be on, independent of their developmental age and their stage of illness. And that really leads to how to select treatments and design care over time. In the third seminar, we looked at how to use self-report clinical and objective measures to provide further detailed assessment and also how to document a trajectory over time that can then be transferred independently from centre to centre, service to service, and provide an accurate picture of the long-term illness trajectory of a younger person having mental health care. Particularly, you can, I think, start to see in that seminar the need to actually record in standardised ways on standardised platforms the kind of assessments that are taking place and track them over time so that they are transparent to a young person, to a family, to a service, as those additional measures are actually collected and taken forward. In the fourth seminar, we looked about how treatment selection actually operates in an early intervention framework and the extent to which one needs to recognise the hole that a person's currently in, what the ladder or the treatment is to get out of that hole, and then what are the secondary prevention strategies to ensure that someone stays well over time to try and reduce the chance of persistence or recurrence and promote recovery. Really important to say, while clinical staging talks about where a person is at and only goes in one direction forwards, actually recovery is possible at all stages of illness, although the treatments required to get out of deeper and more persistent episodes of illness may be greater and may engrave greater selections of both medical, psychological therapies, in addition with social, educational, employment-based strategies to achieve the best type of outcome. But bringing all that together translates into individual treatment selection. What's relevant to the episode now and what's relevant going forward. And of course, how much do we learn as things go forward and become more elaborate? Do we have to change what we think about those either mechanisms or where the person is at in terms of optimal therapies? In the fifth seminar, we talked about how to take the individual perspective about where a person is in terms of current clinical stage or in terms of current clinical need, and start to talk about the level of care or support that they may require at different stages. As we have many, many more people come into services in the youth particular world, one needs to differentiate quite early on how much additional support and how much additional intervention is likely to take place in order to provide the optimal therapy over the optimal period of time. In association with that, we really emphasize 2 other factors. Needing to track what happens. Whatever prediction you make at the start of treatment, may not be sufficient to see a person the whole way through. We can all be wrong. In fact, we are quite often wrong at the start. Some people deteriorate, some people fail to improve over time. Only a smaller proportion of people that we are seeing actually significantly improve symptomatically and functionally and stay well. So tracking over time and being informed by what happens in real time, by having systems to do that, is critical. The other issue is more than one clinician, multidisciplinary teams of clinicians operating in association with other technologies and with other services to achieve the best possible outcome. So no clinician sits individually just doing what they do, independent of the service system in which they're sitting and independent of the actual needs of a young person. There's a terrible tendency in all of our professions to say what I do is X. And in that round hole, the square peg that is a young person must fit. They must fit in with what we do or I am trained to do, independently of whether that is the optimal intervention for that young person at this stage of illness and at this time in their developmental trajectory. So when we come back to talk about the complete circle of factors that we believe are required to deliver personalised and measurement-based care and early interventions for young people, and the range of assessments that need to take place and the range of measurement-based outcomes that need to be continuously monitored, one of the factors that we identified, and is now the focus of this seminar, is that this process is technology enabled. What we've really struggled with in the past is how difficult it is to hold all of these other concepts in mind concurrently and bring them into actually operation. I think why this has been so difficult in the past, in the 20th century, is that we didn't really have the technology and we were not really technology focused. Most of us didn't have the experience of using technology, using digital systems contiguously to do really simple things, whether it's banking or travel or accommodation or our own entertainment. We weren't aware of the power of technology in the hands of users to actually change the experience in all those other industries. Healthcare, frankly, has been slow. Mental health care has been extremely slow to actually utilize the power of personal technologies to provide experiences back from individual people into those particular systems. They are issues we can now address with technologies if we are smart and if we are willing and able to take on these particular issues. So, what I want to argue or propose is that implementation of the Brain and Mind Centre's Youth Possible is actually made possible through health information technology, digiHealth. Now, digiHealth isn't telehealth. It isn't simply doing what you were doing on the telephone or what you might be doing now with a Skype call, which simply is a proxy for what you would have done if the person was in the clinic with you as an individual practitioner. It's using smart information systems to hold together the complex informations that we've been discussing throughout this seminar series, bring those into real-time consultation and decision-making, and then track continuously the outcome and create a system, a record that is highly personalized and continuously improved by open and transparent interaction with the young person, with their families, with their communities, and shared with other service providers. So digiHealth is the concept. I'm very privileged to be part of a wider group through the World Economic Forum about looking about how we deliver mental health care to 8 billion minds. It's never going to be simply in the 1950s style clinic models or in a simplistic primary care model to reach everybody in need early enough to provide effective health care. It's kind of interesting because the development of digiHealth may well therefore happen quicker in developing countries than in developed countries. In developed countries, the existing clinics, the existing systems, a bit like the poles and wires for our telecommunication networks, are frankly an impediment to modern telecommunication systems, where our clinics can at times be an impediment to modern health care. As a colleague of mine remarked, they're real estate driven healthcare. They're about having a shop front, they're about having a place. They're not necessarily about delivering the best care where a person is, where a young person is, in their school, in their home, in their community, in association with them. Whereas digiHealth is about exactly that. It's not clinician-free help. It's actually clinicians play an even more important role at critical junctures along the digital health world. We are not arguing for a separate digital health world, but one where its smart use enhances clinical care to improve outcomes. And we look specifically at the way health information technologies improve access, efficiency, outcomes, continuity in these particular areas. And so all the concepts that we've developed in association with the Brain and Mind Youth Model, we tried to also look at in terms of how smart technologies would work within that. Now, the one particular platform that we've been working with is the InnerWell platform, which is a spin-off company from previous work from our Young and Well CRC and from the University of Sydney's Brain and Mind Centre with PricewaterhouseCoopers. And important to say that I personally have a 5% equity share in that spin-off company as one of the founders of that particular technology. But InnerWell is just one platform. There are a variety of different combinations of technologies that will come together in other platforms in this particular example. So we're just using this here as an example of the one that we have worked with and the one that we have particularly sought to continuously moderate for optimal use in terms of youth mental health. And it is the one that we've used in association with our own Headspace services and platforms to combine services. And we're working with Headspace and our other more specialized clinics, such as the ones I've been working with, you've seen in previous seminars with Dr. Elizabeth Scott, in other settings, specialist settings, and in inpatient settings to develop. But important to say, it's just one example. Like all technologies, many other platforms will undoubtedly develop. And at the end of the day, it's about digiHealth rather than any specific platform on an ongoing basis. So I want to show you a small video of people who've worked on these sets of issues from a person perspective.
InnerWell changes the way that people can work on their mental health and move forward to wellness. What I love about the dashboard is it helps everyone to be on the same page and it tracks your progress. You can do assessments online anytime. A feature I love is being able to do assessments online before an appointment.
Best thing about InnerWell is that it puts the power in the user's hands. As somebody who might be struggling, that really puts me in control. I think one of the game changers is being able to share your profile with your family, friends or support. And I know that in my position that would have been so powerful to be able to share how I was feeling and what the steps that I was taking are with my loved ones to be able to help them help me. And it's all about me. It's about the importance of all of your health, not just your mental health.
To have a face-to-face conversation makes that easier for me to be able to express myself. Convenience is also really important to me.
It's confidential and secure. This whole dashboard is a complete picture of both your mental and physical health and how they combined. It's made by people, for people, because it's accessible anytime. It gives them a snapshot of how I am or how I am feeling at any one time. It's essential in getting better. If I had the InnerWell platform at the time I needed it, I could have started my recovery process a whole lot sooner.
Great things about InnerWell is that you're able to share where you're at in terms of your mental health with your health professional. Being able to share what your needs are and what's really important to you is actually really empowering. You can actually get the resources and information that you need when you actually really need it.
Trust, empower,
Supported, connected,
In control.
InnerWell, because I want to look after my mental health in a way that works for me.
So if we go to the wider concept then of digital health. So for clinical practice, what digiHealth solutions should do is in fact enable multidimensional clinical assessment. One of the really important concepts being picked up in that video is that people do have complex lives. And people can provide information if you give them the time and the means about their psychological symptoms, their suicidality, their physical health, their drug and alcohol use, their physical health. Issues that help you to clarify what stage of illness they might actually be at and to track each of those dimensions appropriately over time. You know, I'm told all the time, you know, people can only answer one question. People can only do one thing. You know, people can only actually track one phenomena. In truth, people can do lots of things, and given the opportunity, they will comment on lots of things. It's often the nature of clinical practice in its short time frames and focus on one problem today, one problem at a time, one problem per consultation, that undermines the fundamental nature of multidimensional clinical assessment. You know, if a clinician's totally preoccupied with suicidality or risk at a particular time, they tend not to take notice of other issues like physical health or engagement, you know, with school or work. On the contrast, if they happen to be, you know, a mental health worker, they tend not, on the whole, to take into account drug and alcohol and physical health sets of problems. If someone's working within an employment or school situation, they may not be aware of those particular issues and may be afraid to ask about questions that actually do need to be clarified. So, multidimensional assessment at baseline, but tracked over time, a critical capability that runs with digiHealth solutions. Really hard to do appropriately and graph it, figure it, show it, retain it, share it without a technology platform. Escalation protocols, things that trigger other events. You can build into smart systems signals to say people aren't well. So suicidality would be a classic example of that. You can have triggers that say if someone is reporting that they need help, that they are at risk, or there's been a change in their situation, at any time that they enter that material. And frankly, a lot of that is outside the time that they're seeing clinicians. It's at other dark times in people's lives. They can trigger that. The system can recognize it, and we can respond much more appropriately. We're in the business of saving lives along with improving lives. And that's an important kind of capability around escalation. We can use actually the data that we continuously collect from large numbers of people to improve our understanding of illness trajectories. So as we collect data and the work we've published in over 2,000 young people, the more we know, the more we learn. The more we learn about the interactions between things like suicidality and clinical types of illness, the interactions between drug and alcohol use, physical health, and suicidality over time, the extent to which physical health problems drive deterioration in mental health and associations over time. We can understand things that we don't ordinarily just see by looking at large sets of data, and also what is happening then to the individual over time, whether engaging in meditation or mindfulness actually improves the anxiety in the situation, or whether by contrast, activity-based interventions or sleep-wake cycle interventions are more effective than general CBT for other sets of anxiety-related problems. We can see from the data what is actually happening over time and learn with a young person and their family or carers what is the best combination, what works specifically for the young person receiving care, and develop better understandings, generally speaking, of what is working in the populations that we're actually looking after. We can actually have people go straight to care. The difference between ringing up and getting an appointment anywhere or brief screening anywhere is you end up waiting. It's been unfortunately our experience that the more demand there is in the youth mental health area, the more waiting there is. Oh, excuse me. The more waiting there is to see, in fact, a health professional. There isn't a starting of an interaction. Immediately in association with technology, people can commence interventions at the point that they log on. Self-care strategies, CBT strategies, enlisting the healthcare of others, being in contact with services, taking actions immediately at whatever stage of care you're at can start you on the pathway that's appropriate to the level of care. So by having those things preset and understood, we can actually make progress. Actually being transparent in what we show people really underpins shared decision making. We talk all the time about making decisions in partnership with young people and their families, but are we operating from the same information base? Are we actually talking about the same thing? Are we actually looking at what the situation is now, or as the situation goes forward, what the real-time situation is. Has the situation improved? Is the area we're focusing on, the drug and alcohol use or the sleep-wake cycle or the suicidality or the depressive symptoms, whatever it is we're focused on, are we understanding what is known about that particular phenomena, what is happening, and whether what we've done in the past or in the future is actually improving that situation? And is that in fact the focus for that young person at this stage or at that time along their course of illness? Transparency, openness, sharing the wider set of information enhances genuine shared decision-making. Really interesting concept, that, because I would say shared decision-making is critical to ongoing engagement with services. We talk a lot about engagement and having the right coloured waiting rooms and the right kind of bean bags or the right kind of staff or people who look the right thing when people start, which maybe is important, engaging young people that they are in the right place in the first instance. But I'd suggest that making decisions together that are relevant to people's lives, that actually fit with their priorities, and getting that right over time is much more fundamental to ongoing engagement. It's about competency, it's about skill, it's about personalization. And that's what happens when you make open and transparent the basis, the empirical basis for the decisions that you are recommending and whether they can be decided and agreed upon with actually young people and or their families. Or if they have alternative points of view, your own willingness to actually work with those particular issues or why you may have reservations about what is being suggested along the way. Really good examples and really basic issues about psychological therapies, medicines, when to use what combination is appropriate, what people's attitudes are, using data about outcomes, using data about illness type, using data about comorbidity helps to inform that process. Sadly, in most healthcare and in mental health care, people get paid and people respond to activity monitoring, not outcome monitoring. As far as I'm concerned, the best thing that can happen is I see a person, they choose an activity, they have an intervention that works, and guess what? I don't see them again. They go back to school, they go back to work, they're improved in functioning, and there is no further need for clinical intervention because they have responded. But outcome monitoring allows us to look at the opposite. People who are persisting and unwell or deteriorating and reconsider whether we are on the right track. And also taking into account which outcomes actually matter to the person, to the young person. The extent to which suicidality matters, the extent to which return to school or function matters, the extent to which getting alcohol or drug problems under control matters, the extent to which changes in their physical health matter at different times. And working on the agreed outcomes and looking at the reality of, do our preferred interventions, those that are recommended or those that the young person has chosen, actually produce the results that are required. DigiHealth also has a really other important concept, is making open to all of the people involved in a young person's care, whether that's a GP, a psychologist, a psychiatrist, a mental health nurse, a social worker, an educational support person, an employment support person, another physical therapist in a particular way, a drug and alcohol related service, all having access to the same information about the same young person, that their concerns is at the center of our care model. Not that we all behave independently and all keep some kind of medical record, which is non-transparent and not shared, and try to use some back-end system to actually share that, pens and papers, letters, faxes, maybe text messages, maybe the odd phone call to try and do that. But actually, it is the infrastructure on which genuine collaborative care in multidisciplinary clinical teams is built. Again, I'd say this has been one of the major limitations to genuine collaborative care. The Institute of Medicine in the United States, back in about 2006, made the point that in mental health and drug and alcohol, highly collaborative care delivers better outcomes. Individual care, no matter how good you are individually, doesn't. But to do it is actually really hard in real time if you do not have a technology-enabled system that allows everyone to operate with the same data in real time to inform decision-making. So in our view, digital health care for young people needs to have these sets of components and needs to be driven by platforms or developments that can bring together these various elements. Ideally, within one platform, but it may involve a number of different technologies. I'd make the general comment No platform can deal with all of the complexities. No platform can bring together all of the things that are in the digital world, the Internet of Things, if you like, which we'll come to. But platforms or systems should enable a young person to access as many of those other attributes, interventions, systems, mechanisms, methods that are out there as are relevant to their condition. You know, they actually get to a whole lot of other good places through the use of technology that we would not be able to take them through our ordinary clinical services. So if we go to the InterWell platform as the example of this, this is the one we have done the most research about. It's written up in the Medical Journal of Australia last year, in October last year, about the Australian government design and development of this around Project Synergy, the involvement of people in co-design of that particular process, but its actual further evaluation. And the most experience we have with the InterWell platform is around young people. And I particularly recommend the particular article in Frontiers in Psychiatry to you for those who are interested in reading more about how it works at the individual person level, about how people come into such a platform, create accounts, complete surveys, get immediate results, and progress through. It is interesting, in a sense, in the digital world, how much live and interactive digital systems are compared with paper and pencil or even published sets of materials. In the 21st century, interactive systems engage and personalize and take forward many of our most important clinical concepts. They enhance clinical care. They don't compete with clinical care. So, within those particular platforms, we kind of have multidimensional assessment of the 5 key attributes that we've talked about: social and occupational functioning, self-harm, suicidal thoughts, alcohol and substance abuse, physical health, and illness type. It's possible to use questions in each of those domains that actually record those phenomena and then re-display to the person immediately the results. It shows them where they are against other standardized elements. You know, we're used to, in other areas of medicine, not knowing, or clinical practice, where we are. You can feel febrile, but until you got a thermometer to take your temperature, you don't know whether you're a little bit febrile or a lot febrile. And if you're a lot febrile, what you might need to do, in fact, to actually respond to that. A low temperature with a mild fever may not be source for anything more than lie down, and very high fever probably means something different. Well, guess what? Those simple kind of tools, that simple kind of severity benchmarking, the simple kind of things, people don't know until they record. So just by getting the benchmark back from standardized tools, people can work out where they are. And we can say to you, if you're at a certain level, we really, really think you need certain kinds of clinical interventions now or elsewhere, or in combination with others in relation to those standardized tools. And wherever you are now, that's your baseline for tracking over time within each of these sets of domains. So rather than clinicians spending endless amount of time asking those questions in non-standardized ways without benchmarks, people can spend their own time doing that and provide quite accurate information about their own experience. You know, if I ask a person, are you sleeping well? That could have been asked by the computer in a standardized way, and we could have got a standardized score rather than me writing down not sleeping well, insomnia, daytime fatigue, other sets of phenomena on an ongoing basis. The second issue around suicidality, you can build in protocols that immediately a person is over a certain degree of suicidality, which they may or may not know. They can be immediately directed to immediate help, whether that's at 3 in the morning or it's a Saturday afternoon or it's first late on a Monday night. Where can you go now if you're already in that particular area? Again, if you think about it like a thermometer, if you've got a temperature of 39 degrees and you're in the COVID-19 situation and you're coughing up things, you need to go somewhere. And you can tell people that. And you need to tell them how to go there. You can also set up how to respond to suicidality, what proportion of people are likely to be identified in these particular sets of issues. You then can signal to the clinicians, hey, this particular person actually has a risk, a red flag in this situation for suicidality, and somebody needs to respond in the next 24 hours or in the next 48 hours as is appropriate to these particular situations. And you can track what is actually happening. There's been a deterioration in their suicidal thoughts over time. So the person can take actions immediately as notified by a system. Clinical action can be precipitated in these particular areas. What we find is that about 30 to 40% of young people in these sets of situations actually have. Now, in our range of issues, that we have, we set such platforms to be more sensitive necessarily than specific. So we're trying to find people who would potentially benefit from identification. It's not to say they all need to go to hospital or they all need to be dealt with immediately. It's not to send the police around or the ambulance around. It's to indicate what the person can do, what a clinical service can do, how clinicians respond, and what the person can do themselves immediately, what they can do in the cognitive behavioral program, what they can do in terms of a safety plan, what they can do in involving somebody else in their care at that moment to promote actions immediately in those particular areas. Obviously, a very important issue to have immediate and effective actions and then follow through on those who may have suicidal thoughts and behaviors. When you're really trying to track people over time in complex systems about their illness trajectories, you've got complex syndromal developments of various sets of symptoms over time, being able to show people in dashboard type factors where they are actually at. Where are they low on particular scales? Where are they high on particular scales? Where are they particular risks? Being able to also incorporate their health priorities. You can combine your own thinking about stage and pathophysiological mechanisms with the recordings that you're actually showing people over time. Often people say to us, oh, why do you want to show people a lot of information? Why don't I just tell them one thing? Like they've got bipolar disorder, or they've got social phobia, or they've got two things. They've got social phobia and alcohol. Funny thing about your own health, if you think about it, if you could know a lot more about your own health or a lot less, would you prefer to know more or less? And if in fact the complexity of more was led to more decision making and better decision making, and you could prioritize certain aspects of your health to be tracked preferentially, I think you might prefer it. The extent to which you can also bring in other information from things like Fitbit and activity recording to combine with these sets of issues, you can bring data from the individual continuously over time into this discussion as to what happens next in their illness development and their illness trajectory as we try to track over time where a person is and how they've progressed. By combining the notion of staging into digital systems, we're trying to have a situation where people do not wait inappropriately to see a clinician. They start on particular areas as quick as they can, and those who need to see more skilled clinicians see them earlier. So by using these tools, services direct those with more at-risk mental states, those with more severe illnesses, to immediate triaging by skilled clinicians, while those who are then staged appropriately in different stages actually have different pathways of being followed over time, taking into account clinical stage, as well as their needs at this particular moment, which are more complex around risk and service complexity in these particular areas. Again, by being very overt, by showing people what we are saying, we are making clear the basis of our clinical recommendations and then trying to make clear what kinds of care pathways are likely to flow from that. Why, in our view, some people need a lot more specialized care and a lot more intensive care now, and for example, for stage 2 people, the next 24 months for the next few years. Whereas others may only require a much lighter touch with relevant online tools and skill development and clinical supervision by mental health workers with different levels of expertise over time. So the goal is everyone gets the care they need, but there are different levels of care depending on the complexity of the need that you require, that you have. One of the interesting things at the moment in the COVID-19 situation is the expression about what is face-to-face, by which historically, of course, we've meant come into the clinic. And of course, we've meant the other meaning use some sort of telecommunication system. Interestingly, for most health practitioners, that means the telephone. But actually, in most of the mental health world, it actually means a video, some sort of FaceTime, Skype, other sets of technology, which is interesting because that itself is face-to-face. And if you know the person well already, following up people through face-to-face evaluations using video visits may well be as effective as having them come into the clinic, and they may come much more often. In the youth world, they're much more likely to be there on the end of the line than having got to your clinic or not. Many youth services complain about the do not attend rate and the failure to come into the clinic, which is really inconvenient if you're a young person to be at somebody's clinic at 9 a.m. on a Tuesday morning when you really should have been at school or work or somewhere else, and you're supposed to be in their clinic, and then you're supposed to take 3 hours or more out of your whole day to fit in with the 1 hour that you have to do with the clinic, as distinct from, in your own convenience, actually using video visits and clinician times. Now, one of the issues for us is how also efficiently those actual video visits can be used, that face-to-face online, to do things like clinical staging. And this very important study done by our Colombian colleague, Lara Ospina-Polinos, when she was working with us child psychiatrists, to work out actually how quickly she could do something as complex as clinical staging by having all of the information collected prior. As a very skilled clinician, by seeing the person face to face, she was able to make really critical decisions as to which pathway they were actually on. And the extent to which also following people up using video visits, people can take shorter periods of time more often to actually check in, and different sets of health professionals can check in. So you don't have to always check in with the same person, making better use of mental health nurses, psychologists, youth workers, and others in following up people on a regular basis. So actually more frequent contact using systems that are much more convenient to the young person and their circumstances, while at the same time actually making the most use where it's appropriate, in particularly more complex situations, of in-clinic type visits. Really, to come back to my earlier expression, we don't want real estate driven mental health. The ideal situation would be we all virtually or in practice were in the person's home or in their school or in their setting, and not disrupting their setting, that healthcare was coming to them, rather than what historically developed really from the 1950s onwards is everyone comes to our clinic or our specialist clinic or our super clinic or our hospital. Everyone gets herded into the one place out of the context of their normal life, and in the most disruptive and expensive ways, most inconvenient ways possible. New technologies allow us to actually engage more effectively. And really interesting, I hear every day of the week, people must come to the clinic to engage. Okay, do you realize how inconvenient it is to come to the clinic from school, from work, from your actual life, and it costs time and money and effort? How engaging is it really? And what about those people who don't want to come? In the earlier videos, you saw people commenting about the privacy, the confidentiality, the convenience of actually using new technologies in your own home, in your own time, to answer questions, to actually provide more information, and times when it suits you, not at the convenience of the other. So I think it's a really interesting issue. When people discuss engagement in person in the clinic, they rarely discuss who they didn't engage with and who didn't attend and who doesn't like coming to the clinic and who might prefer to use alternative methods. This is one of the really, really interesting areas of ongoing research and development. And of course, there are horses for courses. Different people will have different preferences in different settings and levels of availability. In many of the situations where there's more complicated mental health problems to be resolved, in our view, there'll be some combination of in-clinic face-to-face, video face-to-face, and then other sets of issues about skills monitoring, other things which do not require the clinician to be present, but can be supervised by the clinician remotely and information provided on an ongoing basis. I would make the general comment, the more research that's done in this area, the more it challenges many of the ideas about how special it is to be in the clinic, as distinct from how inconvenient it is to be in the clinic, and to what extent many, many other factors, many other skills, many other processes can actually be more appropriately provided through online technologies and monitored. There are always going to be more complex situations, more complex behaviours, certain aspects of mental state examination and following, which will require being in the same place as the person, be that in a clinic or their own home or in their own environment, for more detailed and skilled clinical assessment. But having that as the base of most of our systems at the moment limits our capacity to actually connect and care for as many young people as possible. Shared decision-making is a critical kind of idea. In these particular platforms, the InnerWell platform we have, there are areas that clearly identify your health priorities. What is it we're going to work on in particular ways? And then, who's really working on it? the extent to which it's been prioritized and picked up by the person themselves, how many clinicians are actually working on it, who is doing what, and making everybody, including the young person themselves or their family member, accountable for what is actually happening. Being very clear what people are doing. For example, if they're using the Smiling Mind app around the types of mindfulness types of approaches that are appropriate, is that actually happening? You know, is the person actually using that care option? You know, them committing and following whether that's actually working for them and finding out whether that's working or not. And running through a range of care options that are open to the person directly and are there choosing, but can be supported by the clinician, but also what the clinician can say, what I can do with you. What are the things that my service does with you? And I might importantly say, what are the other options that my service doesn't do, but the service down the road does do, or you might require? And then agreeing that that care option is actually being pursued in an important way. Those care options often start with the easy ones for a person to take on and move into more complex ones, and that needs to be discussed. And it's continuously recorded and then taken forward in the system. And the information is kept and shared and fed back. Person's priorities may change over time as the situation changes. What's agreed to work on over time may change. The need from a clinical point of view to involve different services. If the service the person's attending doesn't have the full range of options open. Also, continuously enhancing what are the options that the person themselves may choose to undertake. In a trial and error way, finding out what works best for them, what's most convenient, what do they find to be most useful. Care options is a really important set of issues. There are a lot of other options out there. Most discussion of digital health and e-mental health gets down to just talking about apps and e-tools or online functions, of which there are estimated at the moment to be more than 20,000 in the anxiety and depression world alone. Apps and e-tools need to be assessed. We've tended to use that which was developed earlier on by the Young and Well Cooperative Research Centre about a mobile app rating scale, takes into account the feasibility and the evidence base of particular tools as to whether they likely be good or not for engagement in these particular areas. So giving ratings to different tools influences what we take forward as care options that certainly can be chosen for people. And just in terms of what we see in our own platform, people are looking at care options that have been used within the Integral platform. Developing a safety plan with a service, a really high priority, is something that's actually happening and can be promoted more. Accessing psychological therapies online, looking at cognitive behavioral therapy, looking at other sets of issues, using things like apps like Smiling Mind for mindfulness type approaches are all issues that can be pursued and brought in and combined in terms of the care options available to a person. So the great thing about the digital world is it isn't a one size fits all, and there isn't just one option. There are a range of options that can be offered and promoted, and as more information about what are better options come into play, smart systems are likely to offer those more to people. I'm sure you're all aware from using your own other sets of systems, every time you open your phone or you open a new online resource, something gets offered to you that actually seems peculiarly relevant to you, because it is. Because information has been built around people like you as to what it is that most likely to be relevant. As we build on more information around young people for certain stages of illness or types of illnesses, bringing to their attention those care options that are most relevant. So when people will say to me, oh, what is the best app for an eating disorder, an anxiety disorder? Okay, well, that's not really the question. The question is, what are the right care options that are most relevant to this young person? And what they've told us, the more they've told us, the more we can feed back what are the care options that may be best, whether apps, an e-tool, connection to another social group, access to another services, the range of options that are out there. We can bring the world that is out there in a way that is more relevant to that young person. We've spoken a lot throughout this seminar series about measurement-based care. Outcome monitoring cannot be something that is just done in research trials. In fact, probably the reason research trials have their much bigger therapeutic effect, independent of which intervention you get, is twofold. One's better assessment and the other's outcome monitoring, continuously going back and seeing whether people are better or not. So we see an illness model of what people might be happening. What we really want to track is what is really happening over time in key areas. What is happening in terms of the key dimensions we were using earlier on, but also bringing in other factors, what the person is saying themselves, what the clinician is saying, what the other supportive others are saying, but also what things like wearable devices might be saying. Is the person actually doing the activity schedule we talked about? Is the person actually monitoring some key aspect of activity. So bringing in more devices, more reporting allows us to develop a richer picture of what is actually happening over time. And of course, what's working, or more importantly, what's not working. If a range of interventions we have chosen are not working, at what point do we say, got to do different, or have we misunderstood something about this particular illness trajectory? One of the other key things that's essential to digital health is actually promoting collaborative care. In this particular diagram, different services are shown in different colors with different sets of clinicians within those services. Once you have standardized assessment triage processes, technology-enhanced care planning within a particular service, you can actually work with more services. So you have more collaborative care within a service, clinicians shown in different shapes and colors here, working effectively within services, and then also sharing that same information with other services, while technology is constantly looking from a review point of view about are we achieving our outcome goals. Now, at the moment, we mainly have collaboration between clinicians within services, but there's no reason we can't have collaboration with clinicians across services if they're sharing the same database and sets of technologies. So going back to my earlier point, we have known for a very long time, collaborative care works better than any individual care. You want to get a good outcome, you want to have what's most relevant, you need to have collaborative care. Now, in many areas of clinical medicine, a surgeon can't operate on their own. A radiotherapist can't operate on their own. A person can't prescribe chemotherapy on their own. There are very few areas of medicine where for complex disorders or chronic disease, an individual clinician can achieve a very good outcome. Unfortunately, in mental health, there's a tendency to think the interaction with one clinician is the key intervention, the personal connection. Collaborative care actually gets better outcomes. To collaborate well, you need to share information in real time and put the person's particular experience and their ongoing experience at the center of that collaboration. When we talk about the future of digital health, we are really talking about the Internet of Things. There are many, many things out there in the internet world, in the digital world, that we will bring increasingly into the interaction with a person's experience and their own context. More recording devices, more smart systems, different ways of doing things, out of the gaming type world, where people are, how they're operating, what they're taking, and then providing further information into these particular areas, as well as the potential for better and complex other systems where they are able to access things like brain imaging and better other recordings, the objective measurements we talked about earlier on, or actually providing further interventions through things like virtual reality and other sets of devices. The information that sits in all these systems can increasingly be shared through so-called open APIs that actually allow the data about the same person to pass from system to system. So they're not all operating independently themselves. They're all providing a richer picture of the young person and their experience. And that's what we've tried to do in designing the InnerWell platform, is think about, no matter which service you come in through, whatever its brand name, wherever it is, and whatever information is collected within that service, that can be shared with any other service that you may actually also be using concurrently or subsequently. But at the same time, you'll have access to many of the other digital systems that are out there, or peer systems. I mentioned Hello Sunday Morning in particular, which is a peer-run system for controlling alcohol use, particularly in young people, to join other systems that are useful. For us, the sharing of information between systems, the access to the wider set of capabilities that online technologies essentially, or digital technologies essentially bring. There's some pretty important concepts in here as well. Information-wise, we see the young person as being in control of that, although they can share that as much as possible with family and other carers or with other services. And that essentially, these sorts of systems don't need to be dependent on the kind of device that you actually use or have access to. One of the issues is making sure that digital infrastructure is shared and open in ways that people can readily access and make use of.
Receiving the right care enabled me to enter into tertiary education and to provide more career options going forward.
Sam's one of our favourite persons. He was a National Mental Health Commissioner with me on the National Mental Health Commission. He's also on the digital safety issues for mental health with the Australian Quality Safety Framework. But his own experience from rural Australia was, got to get good care Care's got to be coordinated. Technology provides enhanced access to care, but also the monitoring of the care provided. So for us, a digital health solution is a model of care plus a health information system. The model we've discussed in the previous 5 seminars is an enhanced model of care. More assessment, more tracking, more personalization. To achieve that over time, to have measurement-based care, you need a health information system. In our own case, the one we've worked with most is the InterWell platform with dashboards, with tracking, with escalations, with clinical care. That has been one that's been supported by the Commonwealth Government and is actually a TGA-approved software device for supporting clinical care. We continue to evaluate its utility in our clinical trials, particularly with young people. Whatever the actual technologies you have access to, if you're thinking about seriously using an enhanced model of care, then the service you work in and the clinician that you yourself try to be has to think about, how can I take these things that we all own, these phone things, these incredibly powerful technologies, put them in the hands of young people and their carers and their families to make sure that we actually are all committed to the most effective care. For us, it's about best care first time, and then the continuing care to achieve exactly the outcome that Sam was just talking about. Back to school, back to work, back to productive lives on an ongoing basis. So just to reiterate, this is the 6th of the series. It will be uploadable with the rest of the series. The Medical Journal of Australia supplement on the whole model of care, very important. The other supplement is on the technology development to go with this on an ongoing basis. And the continued use of this webinar series for ongoing training and education around better mental health care is critical. This has only been possible to develop these series through the support of our partners, particularly Future Generation Global, investment banker type people who want to really invest in these issues on an ongoing basis for young people for the future, and from many of the families of young people who've received care who want that to be shared. And it's really interesting. The families, better care. The bankers understand smart technology, smart 21st century systems. They can't operate in their world without smart technology. They aren't using ledgers and paper and pencils anymore. Their whole world has been digitized to be effective in that area. Our worlds in digital health need to go with that as well. So I'm very grateful for the support that we have, and thank you for your time.